Mohs is not for every skin cancer, but it is often the strongest choice when the true tumor edge matters most.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Now, I can practically hear you interrupting me right now to ask the big question. The one you're actually thinking. Wait, do I actually need Mohs for my skin cancer, or is a standard removal enough? Well, to answer that, we've got to look at the invisible problem that Mohs surgery is specifically designed to solve. You see, the visible spot you're looking at on the skin, that is not always the entire skin cancer. It's kind of like an island with hidden coastlines extending way beneath the water. Tumor cells can send these narrow, highly irregular projections much farther into the surrounding tissue than the eye or even a finger can detect. So we have to define the surgical margin. And what's that? It's the rim and base of tissue around and beneath the tumor. If we just guess a safety distance on the surface of the skin, we don't truly know what's hiding out there at that edge.
Okay, so let's dive into this concept a bit more. To ensure the cancer is truly completely gone, we need what's called a complete margin assessment. Think about a standard removal for a second. It's kind of like cutting representative vertical slices from a loaf of bread to see what's inside. But instead of just taking those representative slices, Mohs completely flattens and orients the tissue layer. This allows the surgeon to examine the mapped, peripheral, and deep boundary as one continuous surface. Basically, we are looking at the entire relevant edge, literally completely removing the guesswork.
Right, so how does this actually play out in practice? Well, step 1 is identifying the visible tumor. Step 2, the surgeon removes a thin layer of tissue. Step 3 is absolutely crucial. That layer becomes a map. It's marked, flattened, frozen, and put right onto slides so the surgeon can examine the complete margin. That's step 4. Now, if cancer remains, its exact position is marked on the map. And that leads us to step 5, where more tissue is removed, but, and this is key, only from the specific location where the map shows the cancer remains. Finally, once the tumor is entirely cleared, we proceed to step 6, which is reconstruction.
But hold on, you might be wondering, doesn't standard excision also check the margins? You just send the specimen to a lab, right? Isn't that exactly the same thing?
Actually, no, they are not exactly the same thing. Now, standard excision is a totally sound, guideline-supported treatment, for sure, but it relies on a planned clinical margin. The tissue is sent away, and the pathologist usually looks at representative vertical sections. Again, it's like looking at those selected slices from a loaf of bread. Mohs surgery, on the other hand, gives you a complete, mapped edge that is examined during the procedure itself.
Now, a really fascinating concept here is tissue preservation. And to be clear, this does not mean leaving cancer behind. What it means is avoiding the unnecessary removal of completely uninvolved, healthy tissue while still achieving those clear margins. I want you to think about high-stakes anatomy for a second. An eyelid, a nose, a lip, or an ear. On these really constrained areas, just a few millimeters of tissue can drastically affect function and completely change the complexity of the repair. Because Mohs maps the exact location of the remaining cancer, we can actually save every possible millimeter of healthy skin. It's a real game changer.
Okay, let's do a quick reset here and bring it back to the core unresolved question of this whole explainer. Do you actually need Mohs? Well, to make that decision, we need to look at the strongest data comparing these two approaches. And we also need to understand exactly what makes a tumor's invisible roots so unpredictable.
Let's take a look at this data regarding recurrent facial basal cell carcinoma, or BCC. When a facial tumor is already returned once, it can track really irregularly right through the scar tissue. That makes the visible border highly unreliable. In a randomized trial that tracked recurrent facial BCCs over 10 years, the recurrence rate after Mohs was just 3.9%. But after standard excision, it was 13.5%. That is a massive difference. This is exactly why, when a facial BCC is already returned, the strongest long-term randomized comparison heavily favors Mohs.
We also have this incredibly striking number to consider, 2,752. This comes from an observational cohort of very high-risk cutaneous squamous cell carcinoma, or CSCC, tumors. In this huge group, using complete margin assessment was associated at 3 years with lower local recurrence, lower nodal metastases, lower distant metastases, and lower disease-specific death when compared to vertical section excision. Now, while this was an observational study and not randomized, the sheer volume of cases and those clinically critical endpoints strongly support choosing a complete margin approach for very high-risk CSCCs.
The absolutely crucial point here is that no single factor should ever be read in isolation. It's like a giant puzzle. The decision for Mohs becomes much stronger when compounding variables start to stack up.
We're looking for things like recurrent tumors, aggressive pathology under the microscope, indistinct or scar-like clinical borders, high-stakes anatomy where function really matters, patient immune suppression, or even symptoms of nerve involvement. Basically, the harder the true edge is to predict, and the more every single millimeter matters, the more Mohs can add value.
So that brings up a really logical challenge, right? If Mohs is so precise and it protects healthy tissues so well, why not just use it for every single spot? Should we just throw out standard treatments entirely? Well, no, we absolutely shouldn't abandon standard treatments. Standard excision is actually an excellent choice for many primary, well-defined, lower-risk tumors. This is especially true on forgiving sites, like the trunk or an arm or leg, where taking an adequate planned margin doesn't carry any meaningful functional cost. Furthermore, invasive melanoma generally follows a completely different pathway altogether. That pathway is built around tumor thickness, staging, and guideline-directed wide local excision.
It's also super important to understand the role of your initial biopsy. You see, a partial biopsy diagnoses the cancer, sure, but it does not define its full edge. Sometimes you might see a pathology report that notes a negative margin on a small diagnostic sample. But listen, that does not guarantee the entire clinical tumor and its hidden roots were removed. A superficial biopsy might completely miss a deeper, way more aggressive component of the tumor that's just hiding right out of reach.
Now for the section titled The Boundaries of Mohs, and its subtitle, What the Procedure Cannot Guarantee. Look, while Mohs establishes that the mapped margins examined during the procedure are clear, no treatment on Earth offers a 100% guarantee that cancer can never return. Plus, while it avoids taking an unnecessarily wide blind margin everywhere, it still has to follow the true tumor. So it doesn't automatically guarantee the smallest possible scar. And this is vital. Mohs treats the local skin tumor. It does not, by itself, treat cancer that has already spread to lymph nodes or distant organs.
As we close out this explainer, I really encourage you to read the full Skin Trust article so you can review these specific variables. Then, sit down and discuss your individual plan and risk factors directly with your treating clinician. Dr. Hocker created Skin Trust to provide free evidence-based dermatology education and help patients and clinicians make clearer decisions together. Make sure to click forward to the next Skin Trust question so we can continue exploring your options.